Okay, and this week we got the case that ended up being diagnosed as polymyositis. I'm going to try to convince you that there isn't enough information to distinguish this from polymyositis from dermatomyositis in this case. However, we can rule out an inclusion body myositis. You can't rule out dermatomyositis, and in fact, there's probably a little more evidence for dermatomyositis than for polymyositis. So I'm still working with the working diagnosis of dermatomyositis. So what we have here with the chief complaint is we've got some type of arthralgic pain, joint pain, we've got muscle weakness, and we've got fever. So fever is probably going to indicate some type of inflammatory pathology. And the joint pain and muscle pain, what we got to do with these is we've got to rule out other common causes such as infection. So if you have joint pain and fever together, a lot of times that could be an infection. However, weakness, you got to distinguish this from a pseudo-weakness. And so that's something you do with the strength testing, but also with the history. Then furthermore, when we talk about weakness, we got to talk about where the weakness is coming from. So anywhere from upper motor neuron, lower motor neuron, neuromuscular junction, or myopathy. That's if we can distinguish it from a pseudo-weakness, and pseudo-weakness would include things like fatigue, or stress, or drowsiness, those kind of things. Now also let's look at the history. So she had pain starting out, and then it moved to her right. It started in her jaw, then moved to her hand and her right hand and knee, then it moved to her left hand and knee. And she also has muscle weakness, redness on her face. I think this is a key thing. Itching on her face, and fever. Now joint pain is often common with autoimmune diseases. So things like rheumatoid arthritis, RA. And this would also be present in cases where you have inflammation. So the fever would not necessarily be uncommon. So rheumatoid arthritis can often cause a low-grade fever. It wouldn't, however, cause a true weakness. It would cause a weakness due to pain, so that would be another kind of pseudo-weakness. Now, one of the things we're going to want to do is look at whether or not we have neuropathic or myopathic causes of weakness. Once we determine she can't lift her head against gravity, she has reduced strength in a lot of different proximal muscle groups. And so proximal muscle group is another key. So proximal versus distal. If you have neuropathic weakness, you're usually going to affect distal first, but proximal is going to usually be due to myopathic, with a few exceptions. So we're going to do strength testing. That's going to help us focus in on where it's at. Another thing that we're going to do is we can do an MRI to look for edema. So MRI with edema. And the best thing we can do is do an EMG. Now remember, if there is edema, the EMG can have a little bit of a trace of low amplitude peroneal potentials, but that would indicate nothing exactly. So we do these things and we find out that it's probably myopathic. And of course I'm not going through this in the exact order of the case. I'm just going through this in kind of a logical order of each thing that we want to look at. Another thing we do in the strength is whenever we do the neuro exam, we find that there's decreased muscle strength in all the proximal groups, but we also find that her reflexes are 2+ in all reflexes that are tested. So that really rules down both upper and lower motor neuron. If it was lower motor neuron, we'd have 1. If it was upper motor neuron, 3 or 4. And supposing there would be a thyroid problem, the reflexes would also rule that down as well. So right now we've basically got 2 major categories that we can look at, or really if you want to do 3. But we've got a myopathy, myopathy or an infection. And right now it's looking strongly like a myopathy due to the muscle testing. An infection may be able to cause a myopathy, so there's a little bit of overlap there as well. However, we cannot also rule down vascular at this point, and the reason for vascular is because of the redness, the rashy type issues. With vascular problems, you can often get a rash. So you can get a rash, for example, on the chest if you have a pulmonary embolism. And within these myopathies, I think a strong consideration is autoimmune, and that's also going to go with her family history, which I didn't go over, but she has a family history of autoimmune diseases. And at this point, just from a history and physical exam, we should have a polymyositis, dermatomyositis, or inclusion body myositis high on our differential. It shouldn't probably be at the top yet, but it should be very high on the differential diagnosis. The fact that she has a rash with itching on her face would put dermatomyositis at the top of this list. Now, in the physical exam, what we find was she has a dry mucosa, which is very nonspecific, tachycardia, very nonspecific, mild tenderness in the abdomen. Now, in the extremities, we find some edema, pain, joint effusion in the knuckles and knees. Now, this is another key thing. It's called Gotron's. So, Gotron sign is basically you have some type of rash-like thing on your knuckles, of the knuckles of your hand. And so this is what would distinguish dermatomyositis from lupus, because a lot of the findings of DM and lupus are the exact same, but on lupus you have the rash covering the entire surface of the fingers, whereas in dermatomyositis it's only on the knuckles. And same down here with the skin, you have cracked skin on finger joints, puffy face, and a macular patch on extensor surface. So the extensor surface of what is what I'm wondering. It didn't actually say, but if it's on the extensor surface of the hand knuckles, that is Gotron's sign. This macular patch or this rash on the knuckles. And it's one of the key signs for dermatomyositis. It's important also to note that there was no malar rash that was found at present. So malar rashes are both found in lupus, systemic lupus erythematous, and in dermatomyositis about 20 to 40% of the time. Also, no mention was made of Shaw sign. Shaw sign is basically if you have a V-shaped rash on the chest, neck, or back, and that is it's usually in a photo-sensitive area, and that's indicative of dermatomyositis. But of course, the exam did say that there was no photosensitive rash apparent at the time of the investigation, so maybe perhaps they were looking for that V-shaped rash. So the next thing we do is some lab work. We get a CBC, and what the CBC tells us, we have a slightly elevated white blood cell count, and in that the largest increase, the out-of-range increase, is with the granulocytes, or probably the neutrophils. And that probably is just indicative of a stress reaction, where with stress, cortisol causes demarginalization. It demarginalizes the neutrophils, and what it typically happens is, here's your blood vessel. Neutrophils can either be attached to the side, kind of crawling, or they can be free-floating in the blood. And the ones that are free-floating in the blood are the ones that get picked up whenever you do a blood draw. If they get demarginalized, it's going to falsely increase the neutrophil count. Now, the range for white blood cells is 4.5 to 11 times 10 to the third, and where we were at was 14.7 times 10 to the third. So it was a little bit increased. It could indicate an infection if we're expecting an infection that's still on our differential. But you always have to have demarginalization as one of the key things that you're thinking about with an increased white blood cell count. On the complete metabolic panel, what we saw was increased transaminases. Sometimes this is called transaminitis. However, a lot of clinicians don't like to use that term because it's saying that the transaminases are the liver enzymes. It's saying that the liver enzymes are inflamed. You can't inflame an enzyme. You can just increase the enzyme count. So increased transaminases, that includes AST, ALT, and creatine kinase. Now, here's the key thing. You have to correlate this with the physical exam, where no hepatosplenomegaly was found. In the abdomen, it's just mild abdominal tenderness, and it was kind of diffuse, but there was no hepatosplenomegaly. So we can keep that in mind for now, but it's not a huge deal. Because you can get transaminases from the liver. You can also get them from muscles. However, the other thing that should kind of keep liver up on the differential is a decreased albumin. The albumin is low, and whenever you have a low albumin, there's a couple of reasons that can happen. You can have just the liver decreases production due to pathological state. You can have some type of sudden increase in fluid. You can have third spacing. So if or you can have loss through the kidneys, so excretion. And we want to look at our inflammatory markers. So we do the ESR and the CRP. So the erythrocyte sedimentation rate is increased, and the C-reactive protein is also increased. So we have an active, a very acute phase inflammation going on currently. This really rules things down to some type of immune-mediated response. So you could have autoimmune right now, or we could have a tissue damage with infiltrate. So you could have trauma, or you could have an infection. The next thing that we see is the urinalysis. And the urinalysis, it had some features resemblant of acute tubular necrosis. And the main feature of that would be that it's brown. So it's described as brown, muddy casts. Although it doesn't list any casts, it does say that there's a moderate amount of epithelial cells. This is often seen whenever you have muscle damage. It can damage the myoglobin can, well, it's not often seen, but myoglobin can damage the endothelial cells of the kidney. And also if you have water moving into the muscles, which we have evidence of some type of, from the dry mucosa, we have evidence of some type of dehydration. So if water moves into the muscle, we can have decreased perfusion to the kidney, and that will also cause acute tubular necrosis. Now the nitrites were negative, or the nitrites were negative, but we did see bacteria. It could just be because of a dirty catch. So you got bacteria living on every part of your body, the skin, and so if you get bacteria mixed in the urine, it just means it probably got there from somewhere else if the nitrites are low. It's not always the case, but it's mostly the case. Next, it's noted that her joint pain is getting worse and that she has effusions bilaterally. So we want to go ahead and check for bacteria, and bacteria and viruses. So she also has the rash on her legs that's getting worse. It's so the rash on the legs and the joint effusions could represent a couple of different types of bacteria or viruses. So in the bacteria, with these, the common causes of joint pain for bacteria would include Lyme disease, which is Borrelia burgdorferi. You can also have gonococcus, so Neisseria gonorrhea. Mycobacteria and staph we didn't check for, but those are also common causes of joint pain with infection. And then Chlamydia trachomatis, this also presents with a rash, and also oftentimes with moderate abdominal pain, which she did have some slight mild abdominal pain. Viruses that can cause joint pain is like parvovirus B19, and the big thing is with this is called Fifth's disease, and it usually presents with a hand slap rash on the face. So any type of facial involvement would be indicative with joint pain of parvovirus. Rubella, mumps, these things usually get vaccinated against. We didn't test for these. HIV is a common cause of chronic joint pain, and then you have Epstein-Barr virus, which is going to be mono. And so you can check, we did 2 tests for mono, and we came up negative on both of those. I couldn't find anything where this specific list also caused myopathies, but I'm sure there's crazy things where that can happen as well. Now our patient also started having difficulty breathing and stuff, so we just did a complete workup. We did chest x-ray, we did EKG, echo, we did a CT and an MRI, and the main thing that was found was we found a lot of edema. We found, so on the chest x-ray it was nothing, there was nothing that was diagnostic. There was a possible pneumonia and or atelectasis. So in all of our findings, we find that the lungs are affected somewhat, the heart is affected somewhat. We had a tachyarrhythmia. I'm sorry, it may not have been an arrhythmia, but it was a tachycardia. We find a lot of muscular edema, and so we're going to go ahead and do a muscle biopsy. Oh, and also the EMG that we did indicated a myopathy. So myopathy would explain heart and lungs as well. So with decreased tone in the diaphragm and stuff, you would have decreased lung expansion, and that could cause atelectasis. And then after the muscle biopsy, we also do an autoimmune panel. And the autoimmune panel had a 1 to 80, which it's high, but it's not extremely high. It was within range for rheumatoid factor, but it was positive for anti-Jo1. So the anti-Jo1 antibody was positive. So this would indicate either dermatomyositis or polymyositis. And so you got to go through and figure out which one that is from the biopsy. So with the biopsy, what we saw was, the first thing we noted is that the muscle fibers are different sizes. So see this small little muscle fiber here, a big muscle fiber here, a medium-sized muscle fiber here, and so another smaller one, larger ones. All of these muscle fibers are different size, and what this indicates is that the muscles have been dying and regrowing themselves. In fact, we can see right here a group of regenerating muscle cells. They're regrowing, and they're staining darker because of the different composition of proteins that are expressed whenever you regrow. On this slide, it's described in the case as being an endomysial infiltrate. Now, I'm not completely convinced that it's endomysial. In fact, I thought that this might be a vessel. I don't know, though. These definitely seem to be lipocytic or fat cells. However, if it is an endomysial infiltrate, that would indicate more towards polymyositis or inclusion body myositis rather than dermatomyositis. Now I'm assuming in the next slide that it's actually the histochemical stain, and we're just zooming in a little bit further. So here's the interesting thing. It's harder to see on this software, but right here you see this ring of cells, and then again up here a ring of cells. To me, these look like areas of vasculature. And what's important to note that is we're doing an immunohistochemical stain here, and we're staining for T cells. We're doing a CD3. So CD3 is any and all T cells, and to a small amount, Purkinje fibers will also express CD3. But those are the only two cell types that we know of that express this protein. So if we stain these, we can basically identify where the T cells are. And so these dark areas would be the T cells. And what's important to note is that you find it in this vascularized area and not in the endomysial area so much, although to a small extent you do. This slide was showing the fiber type regrouping. I'm not even totally sure that I agree with this, because it's saying what happens with fiber type regrouping, if you want to distinguish a myopathic versus neuropathic, and this was explained to me in a group objective. I haven't found this in a source anywhere. Of course, I didn't look extremely hard. With neuropathic, you'll have some deinnervation, and the reason that's important is because you have two types of muscle fiber. You have fast twitch and you have slow twitch. And what determines whether or not it's fast twitch or slow twitch is the type of nerve that's attached to it. So if the nerve is attached to this, it will be a fast twitch nerve is attached to the fiber, it'll be a fast twitch muscle. If you get nerve damage, for example, in a slow twitch muscle, the closest other nerve is going to reinnervate it. And when the other nerve reinnervates, it'll change the type from one to the other. And so you get these fiber type groupings. However, here's the thing. I've looked at a lot of these pictures in the last couple of hours, and the only place where I actually see a large group would be right here, and then maybe perhaps right here. But everywhere else looks just like a normal muscle. So I'm not even totally convinced that's what we're looking at here. And from what I understand, and I could be wrong, it indicates neuropathic problems rather than myopathic. However, the other thing you should know is that once this happens, it doesn't go away. So if you had a neuropathic problem when you were 2 years old and you did this fiber type regrouping, it would never go away. So you would have that presentation for the rest of your life, if I'm understanding this right. And so this could just be something from a long time ago that is no longer an issue. So I'm not totally sure, again, whether this is from neuropathic or myopathic. One thing I was thinking is if a muscle dies, so if this muscle dies, the nerve that's going to it may as well atrophy, and then whenever it grows back, it gets reinnervated by the nerve that's attached to this one. So that could be another possibility as well. I just don't know. The other thing I would encourage everyone to do is get on Blackboard and compare Exhibit 7 and 8 together, and tell me if you don't think that it looks like more of a perivascular infiltrate rather than an endomyceal infiltration. So we got a diagnosis of polymyositis. What this is it's an autoimmune disease. It can be associated with other autoimmune diseases, but you typically don't have as much overlap syndrome as you do with dermatomyositis, and it can also be related to some cancers. And what it is a T-cell mediated attack against the actual muscle cells themselves, the sarcolemma. Or not necessarily the sarcolemma, but maybe perhaps proteins that are inserted into it. Mechanistically, this is distinguished from dermatomyositis because dermatomyositis is an issue where you have a T-cell mediated attack against the endothelial cells of the microvasculature. So I'll put microvasculature. And it usually presents with rash, and it often includes a periorbital, periorbital heliotropic rash. It's often called a heliotropic rash, and that's a rash around the eyes. And you can also have a common presenting symptom is swelling or puffiness of the eyes and face. And according to a lot of the research I read, polymyositis is the most it's the most inaccurately diagnosed myositis. The occurrence of either of these is about 5.5 per million, and dermatomyositis is much more common. Oftentimes, whenever you have polymyositis, the misdiagnosis is with inclusion body myositis, but we actually ruled that out by looking for the vacuolated muscle cells that we didn't see. But I did read like 2 or 3 case reports where polymyositis was the original diagnosis and it was wrong. It ended up being dermatomyositis, so that's something to keep in mind as well. The last thing to do is talk about some of the tests that were run and what they would be normal and abnormal results. As far as the microbiology, Molly posted a thing of microbiology on Quizlet, and I have all the pharmacology on Quizlet, so you can check that out. So let's do the joint aspiration. The joint aspiration. So why would you do a joint aspiration? The first thing is if you expect an infectious cause of arthritis, or if you expect any cause of arthritis. So there's different causes. You can have the 2 major types of arthritis would be like an osteoarthritis and then inflammatory arthritis. So osteoarthritis is considered like a wear and tear. And then inflammatory arthritis, one example would be rheumatoid arthritis. You can also get arthritis from the buildup of gout. So crystals in the synovial fluid would also be indicative of a gout, and you would want to check that for birefringence and light. But you do a joint aspiration, especially if you are suspecting an infection. And so what are the indications of a normal aspiration? So the appearance is going to be clear. It's going to have the glucose is going to equal about the same as the fasting blood. Then protein should be about 1/3. And then the really important is that there's no growth from that aspiration. You also want to do microscopy to look for bacteria and various stains as well. You can do ELISA, you can do antibody testing and stuff like that to also look for viral and bacterial infections. And so like I was saying, in the College of Rheumatology website, they break it down as the 2 types of of arthritis, but you can also, I like on Molly's study guide, she has it broken down by group. And if you have a group 1, it's a non-infectious, and it's typically like osteoarthritis, trauma, osteochondritis, and you can have a neuropathic. And the key feature of this is that the white blood cells are between 200 to 300. I'm not sure what the units are for that. And then group 2 is going to be an inflammatory. And the white blood cells are going to be between 3,000 to 50,000. This would be like your rheumatoid arthritis. This would also be the range where you would look for tuberculosis and fungal infections. Then in group 3, so group 3, you have your white blood cell range is going to be greater than 50,000. And this is where you're looking for other bacterial infections. Then in the last type, it's not given a group number, but it's called hemorrhagic. And this is where you would look for malignancy. You would also look for any type of bleeding disorder or vascular disorder. And I already went over the biopsy, so I guess that's it. Let me know if I left out anything glaring, and let me know what you think. Polymyositis, dermatomyositis.